Bipolar and related disorders are separated from the depressive disorders in the DSM-5 and placed between the chapters on schizophrenia spectrum and other psychotic disorders and depressive disorders. This is in recognition of their place as a bridge between two diagnostic classes in terms of symptomology, family history, and genetics. The DSM-5 has clear definitions for three types of bipolar disorders: bipolar 1 disorder, bipolar 2 disorder, and the cyclothymic disorder. In addition to this, there are also conditions for substance medication-induced bipolar and related disorders, and some other specified bipolar and related disorders, and unspecified bipolar and related disorders. Bipolar 1 disorder is a manic depressive disorder that can exist both with or without psychotic episodes. And bipolar 2 disorder consists of depressive and manic episodes which alternate and are typically less severe and do not inhibit some functioning. More inclined to see individuals who are working and living in the world suffering from bipolar 2 disorder, and those suffering from bipolar 1 disorder would have more severe symptoms, and functioning would be more inhibited. Cyclothymic disorder is a cyclic disorder that causes brief episodes of hypomania and then depression. People who live with bipolar disorder experience brief periods of great excitement, overactivity, delusions, and euphoria, which we know or call as mania, and other periods of feeling sad and hopeless, which is known as depression. As such, the use of the word bipolar reflects the fluctuation between extremes of highs, where there's excitement and overactivity and delusions and euphoria, and lows, where there's feelings of sadness, depression, and hopelessness. To be diagnosed with bipolar disorder, a person must have experienced at least one episode of mania or hypomania. And to be considered mania, the elevated, expansive, or irritable mood must last for at least 1 week and be present most of the day, nearly every day. To be considered hypomania, the mood must last at least 4 consecutive days and be present most of the day, almost every day. During this period of hypomania, 3 or more of the following symptoms would be present and represent a significant change from usual behavior: inflated self-esteem or grandiosity, decreased need for sleep, increased talkativeness, racing thoughts, distracted easily, an increase in global directed activity or psychomotor agitation, engaging in activities that hold the potential for painful consequences. So, for example, unrestrained buying sprees. The depressive side of bipolar disorder is characterized by major depressive episode resulting in depressed mood or loss of interest or pleasure in life. The DSM-5 states that a person must experience 5 or more of the following symptoms in 2 weeks to be diagnosed with a major depressive disorder: depressed mood most of the day, nearly every day; loss of interest or pleasure in all or most all activities; significant weight loss or decrease in appetite; engaging in purposeless movements such as pacing in the room; fatigue or loss of energy; feeling of worthlessness or guilt; diminished ability to think, concentrate, or indecisiveness; reoccurrent thoughts of death; reoccurrent suicidal ideation without a specific plan, or a suicide attempt. Bipolar 1 disorder is really defined by alterations between full manic episodes and depressive episodes. The average onset is 18 years, but can begin in childhood. It tends to be chronic, and suicide is a common consequence. Bipolar 2 disorder is an alteration between major depressive episodes and hypomanic episodes. The average onset is about 22 years, but can begin in childhood as well, and only 10 to 13% of cases progress to a full bipolar 1 disorder, and bipolar 2 also tends to be chronic. The cyclothymic disorder is more a chronic version of bipolar disorder. Manic and major episodes are less severe, and manic or depressive mood states persist for long periods, and patterns last for at least 2 years and 1 year for children and adolescents. In terms of average onset, it's about 10 to 12 years, and cyclothymia tends to be chronic and lifelong. The neurobiological influences of the bipolar disorders are similar to those of the mood disorder. Neurotransmitters such as serotonin and its relations to other neurotransmitters impact mood, and mood disorders are related to low levels of serotonin. And the permissive hypothesis of the regulation of neurotransmitters also has a play in being part of a neurobiological influence. The endocrine system, elevated cortisol, and the suppression of cortisol is certainly shown and show less suppression in people with mood disorders. The psychological dimension of the bipolar disorders are connected to stress, and the role of stress in mood disorders, in that stress is strongly related to mood and mood disorders. Poor response to treatment and longer time of remission are impacted by stress, and stress also has something to do with the return of the diathesis stress and reciprocal gene environmental models. The selective serotongenic reuptake inhibitors, or the SSRIs, are specifically lock reuptake of serotonin. Fluoxetine is the most popular SSRI, and SSRIs pose little or no risk of suicide or violence, but there are negative side effects that are common to the use of SSRIs. In terms of the bipolar disorders, treatment of the bipolar disorders is sometimes addressed with lithium, which is a common salt. It's the primary drug of choice for the bipolar disorders. Although side effects may be severe, dosages must be carefully monitored to make sure that the side effects related to lithium are certainly closely monitored. And why lithium works still remains unclear, but it is effective in modulating mood and mania and hypomania. In terms of psychological treatment, cognitive therapy and DBT, or dialectical behavior therapy, address cognitive errors in thinking and behaving, and also include behavioral components. Behavioral activation involves helping a depressed person make increased contact with reinforced events. Interpersonal psychotherapy focuses on the problematic interpersonal relationships and outcomes with psychological treatments and with medications. They are comparable in terms of outcomes, so that's really excellent that we have good psychological treatments to address bipolar disorders. So let's look at schizophrenia and some of the other psychotic disorders. The nature of schizophrenia versus psychosis is really important for you to understand. Psychosis is the broad term referring to hallucinations and or delusions. Schizophrenia is a type of psychosis with disturbed thought, language, and behavior. Psychosis and schizophrenia are heterogeneous. According to the National Outcomes Measurement Study in Schizophrenia, the majority of people with schizophrenia in our country are unemployed and living in poverty, and that was 2006, and I can assure you that that statistic is still valid today. From a historical perspective, the nature of schizophrenia and psychosis begin with Benedict Morale, who looked at the loss of the mind. Benedict Morale, influenced by various pre-Darwinian theories of evolution, particularly those that attributed to a powerful role in acclimation, saw mental deficiency as the end stage of a process of mental deterioration. Emil Kraepelin used the term dementia praecox and focused on onset outcomes, and Eugene Bleuler introduced the term schizophrenia, or splitting of the mind. Buehler was a Swiss psychiatrist and eugenist, most notable for his contributions in the understanding of mental illnesses, and he coined many psychiatric terms such as schizophrenia, schizoid autism, depth psychology, and what Sigmund Freud called Buehler's happy chosen term, ambivalence. Many of these early ideas impact our current thinking about schizophrenia. The understanding of onset and course is still considered really important. In fact, in terms of schizophrenia, if you are working with individuals who are experiencing schizophrenia symptoms, the onset and course must be and should be documented well so that you can provide that information to anybody assisting and supporting in the treatment plan for the schizophrenia. Schizophrenia has a positive symptom cluster. The positive symptoms are active manifestations of abnormal behavior and distortions of normal behavior. Examples of this can include delusions, hallucinations, or disorganized speech. In terms of delusions, we're talking about thinking that some persecutory experience is going to happen, hallucination, seeing things that aren't present, and disorganized speech, talking in a way that is incoherent. Delusions are gross misrepresentations of reality, and examples include these delusions of grandeur or persecution. Hallucinations can be auditory or visual and have something to do with the way sensory events are perceived without environmental input, and can involve all senses: taste, touch, smell, hearing, and feel. So the nature of the auditory and visual hallucinations can be seen within studies, SPECT studies in the brain. Schizophrenia has negative cluster symptoms as well, and these are the absence or insufficiency of what we call normal behavior, and examples are emotional or social withdrawal, apathy, or poverty of thought and speech. The spectrum of negative symptoms include avolition or apathy, referring to the inability to initiate and persist in activities. Alogia, which refers to the relative absence of speech. And hendonia, which is the lack of pleasure or indifference of pleasurable activities. And affective flattening, which is somebody who would show little expression of emotion but still feel emotion, so not seeing it in the affect. The disorganized cluster of symptoms include severe and excessive distortions in speech, behavior, and emotion. Examples include rambling speech, very erratic behavior, or inappropriate affect. The nature of disorganized speech can consist of cognitive slippage, which refers to illogical or incoherent speech, tangentiality, which is going off on a tangent and not answering a question directly, or loss associations or derailments, which is taking conversations in unrelated directions. Schizophrenia is, in terms of the disorganized nature of affect, is inappropriate behavior like crying when one should be laughing, and includes a variety of unusual behaviors like catatonia, which is a spectrum from wild agitation to waxy flexibility to complete immobility. Some subtypes of schizophrenia are the paranoid type, which this particular subtype would have intact cognitive skills and affect, so they're able to think and have good affect, and do not show disorganized behavior. Hallucinations and delusions center around a theme of grandeur or persecution, for example, and best prognosis of all the schizophrenia are the paranoid types. The disorganized type of schizophrenia is marked by disruptions in speech and behavior and flat or inappropriate affect. Hallucinations and delusions have a theme but tend to be very fragmented, and this type develops early, tends to be chronic, lacks periods of remission. The subtypes of schizophrenia continue with the catatomic type that show unusual motor responses or odd mannerisms like echolalia or exopraxia, and this subtype tends to be severe and quite rare. And then the undifferentiated type, which is this wastebasket category, and a residual type, which is where someone has had one past episode of schizophrenia. Other disorders with psychiatric features include the schizophreniform disorder, which is schizophrenic symptoms for a few months associated with good premorbid function, but most resume normal life, and a schizoaffective disorder, which symptoms of schizophrenia and a mood disorder are independent of one another, and prognosis is similar to those people with schizophrenia, and such persons don't tend to get better on their own. The delusional disorders are disorders that are contrary to reality without other major schizophrenia symptoms and may show other negative symptoms of schizophrenia. Types of delusions include erotomatic, grandiose, jealousy, persecutory, or somatic. The condition is extremely rare with better prognosis than schizophrenia. Additional disorders with psychiatric features include a brief psychiatric disorder, a shared psychiatric disorder, and a schizotypal personality disorder, which we'll talk about a little later in the semester. Schizophrenia has an onset and prevalence worldwide of about 0.2 to 1.5%, or about 1% of the population, and it usually develops in early adulthood but can emerge at any time. Schizophrenia is generally chronic. Most suffer from moderate to severe impairment throughout their lives, and life expectancies of persons with schizophrenia is slightly less than average. Schizophrenia affects males and females more equally. Females tend to have a better long-term prognosis, and the onset of schizophrenia differs from males and females. Schizophrenia appears to have a very strong genetic component. From genetic research, we see that we inherit a tendency for schizophrenia, but not specific form of schizophrenia, and other family members are at a risk of schizophrenia. In twin studies, there's a risk that schizophrenia in monozygotic twins is 48%, and the risk of schizophrenia drops 70% for fraternal twins. In terms of genetic research, the risk of schizophrenia increases as a function of genetic relatedness. The closer we're related to somebody, the more risk there is of a function of there being schizophrenia. One need not show symptoms of schizophrenia to pass on relevant genes, and schizophrenia has a strong genetic component, but genes are not alone enough to explain schizophrenia. Other neurobiological influences include the structural or functional brain abnormalities. Some individuals with schizophrenia have demonstrated enlarged ventricles and reduced tissue volume, hypofrontality, less active frontal lobes, a major dopamine pathway, viral infections during early prenatal development, and the relationship between early viral exposure and schizophrenia is inconclusive, but there are studies that explore this area. And the conclusions about neurobiology and schizophrenia is that schizophrenia is associated with diffuse neurobiological dysregulation, and structural functional abnormalities in the brain are not unique just in schizophrenia. The psychological and social influences to schizophrenia include stress, as we spoke about a little earlier. Stress may activate underlying vulnerability and or increase the risk of relapse. Family interactions have a great deal of impact on influencing schizophrenia, and show that families of people with schizophrenia that show ineffective communication patterns have a high expressed emotion in family associated with relapse. The role of psychological factors include only a minimal effect in producing schizophrenia, but certainly have an impact on treatment. Medical treatment of schizophrenia include antipsychotic neuroleptic medications. Medication treatment is often the first line of treatment for schizophrenia. Began in the 1950s. Most of the medications that we use to treat schizophrenia are used to reduce or eliminate the positive symptoms of schizophrenia. and acute and permanent extrapyramidal and Parkinson-like side effects are common, so one has to be careful with the medications that are used to treat schizophrenia. Compliance with medication is often the biggest problem, the problem being that somebody with schizophrenia starts to feel really good and feel well, stops taking their medication and gets in a cycle of not taking medication and then having a return of symptoms that become problematic in their life. In terms of transcranial magnetic stimulation as part of a treatment for schizophrenia, there's relatively untested procedure for treatment of hallucinations. Psychosocial interventions of schizophrenia include historical precursors. Psychological approaches include behavioral, such as token economies within inpatient units, in community care settings, social and living skills training, behavioral family therapy, and vocational rehabilitation. Psychosocial approaches are usually a necessary part of medication treatment. You can see here, if you review studies on treatment of schizophrenia, that drugs and support or education combined compared to drugs and support and skills training in drugs and family stress management is certainly the best approach. So let's summarize schizophrenia and the psychotic disorders. Schizophrenia includes a spectrum of cognitive, emotional, and behavioral dysfunctions, include positive, negative, and disorganized symptom clusters. Several causative factors have been implicated for schizophrenia, and successful treatment rarely includes complete recovery, but treatment is possible, and is possible with the work of a wraparound support for people with schizophrenia.